First tonight is Candy Childress.
My name is Candy Childress. I was born and raised in Kingsport. Over the last 5 years, I've spent much of my working career addressing the health issues impacting our community. As part of this work, I've had the privilege of serving as the Director of Community Impact and Communications at the United Way of Greater Kingsport. I now serve as the Executive Director of Healthy Kingsport, a nonprofit organization founded to promote wellness, enhance infrastructure, and influence policy related to community health in Kingsport. Healthy Kingsport is truly a coalition of many community partners, including volunteers, business leaders, churches, and partner organizations, all who have joined together to create a community who actively embraces healthy living. Last April, Kingsport was chosen as one of Tennessee's 9 pilot communities in the Healthier Tennessee Communities Initiative. We're doing this by encouraging community members to take small steps, what we call small starts, toward a healthier lifestyle. One example of this is our participation in the National Live Sugar-Free campaign, an effort to combat type 2 diabetes and obesity. We are working with our partners to encourage folks to drink water over sugary beverages. According to the Public Good Projects, the nonprofit that's spearheading the Live Sugar-Free campaign, adults in our region, ages 18 to 45, drink an average of 2 sugary beverages a day. 1 in 7 local residents drink 4 or more sugary beverages a day. This type of public awareness and education is a hallmark of our work at Healthy Kingsport, and we are glad to have Wellmont Health System and Mountain States Health Alliance and many other wonderful partners take part in our work. Today, we're at a critical juncture in our community and our state when it comes to obesity and diabetes. And that's why I ask that this committee adopt measures to track efforts designed to address obesity and type 2 diabetes. According to 2014 data provided by America's Health Trust and the Robert Wood Johnson Foundation, Tennessee has the 14th highest obesity rate among adults in the nation. What's more alarming is the rapid rate of increase in obesity in our area over the last 25 years. In 1990, the adult obesity rate was 11.1%. It was 20.9% in 2000, and today we are above 30%. In Sullivan County alone, if you look at people who are either in the obese or overweight category, our percentage is 73%. This type of trend cannot continue. According to the same data, in 2011, Tennessee ranked 5th in the nation for childhood obesity. 1 in 5 children were considered obese. Unfortunately, this is causing a preventable and costly epidemic of heart disease, diabetes, obesity-related cancers, arthritis, declining quality of life, long-term disability, and more. I believe this is one of the most important single issues facing our children and our community today, and I ask that you make this a priority in your planning process. Thank you for the opportunity to speak tonight.
Okay, thank you, Candy. Any questions from the committee? Okay, seeing none, thank you very much. All right, next we have Courtney Perret, I hope.
Again, I'm Courtney Perry. I'm Senior Director of Government Relations for Amerigroup. Amerigroup is one of the 3 managed care organizations in Tennessee in the TennCare program. Amerigroup is a wholly owned subsidiary of Anthem. Anthem also operates in Virginia as one of the Blue Cross Blue Shield Association members in both the commercial market and in the Medicaid market in Virginia. Jeff did a very good job of setting it up and explaining your task, and so I'm going to make some comments on that, but I will not. I would like to say that, as he pointed out, the application has not been deemed complete, so it's kind of hard to make specific recommendations until you know what the commitments in the application are going to be finally. But with that said, I'd like to make a few points about the things we think the index should consider. First, the bedrock principle of Medicaid any Medicaid program, be it Tennessee, Virginia, or elsewhere, is choice. Members must have, TennCare members must have choice as to payers, as to providers, and, as to payers and providers. The COPA application must assure that the TennCare members in Tennessee have access to the services that they need. It is crucial that if the COPA is granted, that the merged entity be required to assure access to needed services by TennCare patients, and that such access be closely monitored and included in any index. 2, the COPA in several places states that Medicaid rates are not negotiable. That might be true in a lot of states that have state-mandated fee schedules, but Tennessee does not. The 3 managed care organizations in Tennessee use Medicare, which is not negotiable, as the basis of their rates, but then we each apply a percentage to the Medicaid rate. It might be less than 100%, normally it is. Could be more. But those percentages are negotiated with every payer, be it hospital or physicians. It's crucial that the COPA, if the COPA is granted, that the index requires the entity to keep its prices constrained for its TennCare patients. Basically what the COPA, if it's granted, it's creating a monopoly. And monopolistic rates are regulated like public utilities, and the index needs to be specific in that regard. Number 3, hospitals compete on quality, and in the application as it's worded right now, the hospitals commit to do certain things in quality, but or publish certain results, but most of those are required to be published anyway. We think it's crucial, if the COPA is granted, that the merged entity be required to achieve certain minimal quality standards, and that these standards are monitored and included in any index. And finally, as I said, it might be a little premature to comment specifically, but I'd like to emphasize 2 more points. First, the index that you will be advising the commissioner about must be comprehensive and carefully considered. It has to address multiple complex issues such as healthcare access, cost, and quality. And second, the index must be dynamic. If the COPA is granted, the hospitals will be together probably for a long time, perhaps forever. But what constitutes appropriate measures for cost, quality, and access today might not be appropriate measures in the future. So the index must be dynamic, as I said. That's a very challenging task. I don't envy it, either you advising on it or the commissioner in devising the final index. I appreciate the time. If you have any questions, I'll try to answer.
Okay. Yes, Dr. Kidd?
Thank you. You indicated a recommendation that the index contain minimal quality standards, but you said the application contained the quality standards that they were already required to report on. Did you have other standards that you would recommend that they report on?
Well, again, I'm not an expert in quality. We have people with our company that are, and we'll be making specific recommendations in writing. But again, until we see a completed application, it's hard to comment.
Thank you.
Yes, ma'am.
I wonder, I've had experience with Amerigroup,
Okay.
and the problem is that Amerigroup started assigning, or TennCare started assigning patients to Amerigroup, but none of the physicians or the people we would refer to take Amerigroup. So we've had, we're going back to the old days when we had to refer to Knoxville, Nashville, way out of our region. So we already have that problem. I'm not sure how to improve it except to go to TennCare. And you're suggesting that because of this merger, we might have more of a problem like that?
Well, you have 2 major hospitals that serve the 8-county area now. If
Right.
it's approved, you'll be down to 1.
Well, I think the whole area has been affected by the Amerigroup thing, so I hope we can fix that.
Right.
Okay. Any questions on on this end? All right. I want to clarify again, if I may. I have a question about the quality standards. I recently read that hospitals have, with Joint Commission and all the other regulatory agencies, some hospitals could have upwards of 3,000 measures they have to routinely report. And I might have been what Dr. Keel was alluding to. So I want to make sure that you said you would have your folks send us your recommendation or your input into the quality standards.
Yes, we intend to do that, yes, sir.
Okay, good. I think that'd be helpful for the committee.
I'm not
I understand.
I deal with the legislature primarily, and I'm not an expert on quality, and I can't give you specifics.
Sure, and that's understandable, but we will begin our working sessions next week, so if the committee could have that in advance of that time, I think it would be helpful. Appreciate that very much.
Thank you. Anything else?
All right, good
Thank
job.
you.
Thank you. Okay, next is Laurie Hamilton.
Hello. Thank you for allowing me to speak. I'm Laurie Hamilton. I've never been told that I was quiet in my life. I'm Laurie Hamilton. I'm a registered nurse, and I am the Director of Healthy Initiatives for KVAT Food Stores, which do business as Food Cities. We are based in Abington, Virginia, and we operate 135 retail outlets in Kentucky, Virginia, Tennessee, and Georgia as well. I am very proud to be involved with our community and have worked with Wellmont, Mountain States, and ETSU over the course of many, many years. I also have served as a co-chairperson for the Population Health and Healthy Communities Work Group for the COPA. KVAT is a self-insured employer with a long-standing history of supporting our community. The last 6 to 7 years, though, we have embarked on a very strategic, focused attempt at helping our community members as well as our associates to live a better life. And so, from a nutrition and food point of view, and as a nurse, I often see the significant impact that unhealthy choices make on a person's life. Unfortunately, as a healthcare provider, and as many of us are aware, we don't often see these individuals or come in contact with them until they have significant disease processes that are going on, which is very, very sad. We tend to be more reactive than proactive, and so that is one of the things that I hope as this partnership goes forward, that we are able to be more proactive in that approach. So opportunity did knock for me. 35 years ago, if you would have said to me when I received my nursing degree that I would be a registered nurse for a grocery store chain, I would have said, you are crazy and you've lost your mind. But this is an awesome responsibility that I have to work with Food City for our associates and the community members at large. So my role allows me really to improve and work to improve the regional health that we have and prevent illness by looking at initiatives that we can implement within our communities that we serve. And we want to keep individuals aware and educate them about their healthy choices or about those choices that they make. We are not telling them what they have to do, but we are providing them with awareness and education. It is my privilege to work with nearly 16,000 associates in all of our states that are working towards Food Cities initiatives for health and wellness. I also work with a wonderful dietitian. I work with the many community partners, Wellmont, Mountain States, ETSU, and we do cooking programs. We do programs related to healthy eating on a budget, fast and healthy, those kinds of things. And we help them in terms of looking at selections for them for their food and nutrition as well. I'm here tonight because I truly do believe the power of our community to address the issues that we are faced with. We need to do it strategically, and our continued partnerships in these areas with our providers, community organization, churches, schools, businesses, and many others are really going to bring this all to fruition there. From a professional and personal standpoint, the investment and the future systems is planning to make will help strengthen the local efforts that we have on early detection, prevention, and disease management. As you develop your recommendations, I encourage you to track the following, especially lower the prevalence of diabetes type 2 in our area, as well as heart disease, cardiovascular disease. These are huge problems within our area, and they are certainly affected by our lifestyle changes and habits that we have. So diabetes, cardiovascular disease, tobacco use is also a huge factor, and for individuals to get cancer screening for early detection and a better chance for successful treatment. As we look towards the future, I'm hopeful that our continued partnership with our region stakeholders and increased investments will result in a culture of health not only for this generation, but for generations to come. Thank you for this opportunity very much.
Thank you, Laurie. Any questions from the committee? All right. Thank you very much. Next, we have Wally Hankowitz.
Thank you, Mr. Chairman. And my name is Wally Hankwitz, and I've lived in Kingsport, Tennessee since the late 1900s. I'm an independent healthcare management consultant with 40-plus years of experience as a senior healthcare executive. I've been a hospital administrator. I've worked with national accounting and management consulting firms, investor-owned and nonprofit hospital systems, and most recently helped roll out a couple of very successful accountable care organizations, including one for the largest healthcare provider in a central U.S. state that was listed among the top 10 of the ACOs in the country this past year. I understand healthcare reform. I've been with it. I've been there, I've done it, community by community, from Denver to Cincinnati to LA, Toledo, Springfield, and even Paducah, Kentucky. And just to name a few, I believe I know what works and I know what doesn't work. I moved my family to Kingsport from Southern California 2 decades ago, drawn by its great healthcare community and the area's strong Christian and family values. Many of you might not appreciate the attributes of this medical community, but more than a decade ago, it was one of the 11 entities selected by CMS to participate in a PGP demonstration pilot. Have you ever heard of Geisinger or Dartmouth or Park Nicolay or Forsyth? Well, they're nationally renowned medical systems and also among the 11 entities selected along with your own great medical community to pilot healthcare delivery reform. The excellence of the medical community in your own backyard is really the best kept secret in the country. And this authority is you, the authority, is in a position to either support and encourage its continuation toward getting even better or destroy it by allowing the proposed merger. The proposed merger will combine the only 2 hospital systems in Northeast Tennessee and create a healthcare monopoly that will control the way healthcare is delivered and pricing for all commercial payers in these communities. The combined entity would own, operate, and control a vast majority of the hospitals in the area and all, if not 100%, of the general acute care inpatient hospital services rendered to all the residents of the Tri-Cities. The result would likely be significant harm to consumers with rising healthcare costs and diminished incentives to upgrade services and improve quality. This merger will significantly increase the combined system's bargaining power with health plans, pointed out by Courtney, which in turn will harm consumers by bringing about higher prices and lower quality. I reference an article written by Dr. Eric Schneider and published in the Commonwealth Fund in November of last year, which states, and I quote, and it's a couple of sentences here I'm going to read, based on historical data, we know that horizontal mergers, hospital to hospital, generally raise prices and spending. Hospital mergers may even accelerate the growth in prices over time. Likewise, physician group mergers seem to be associated with higher prices for common procedures. I continue the quote, and they ask the question, could the price increases be justified by higher quality? Answer, not really. Studies in the US and England tell us that quality tends to be higher when patients can choose among competing hospitals. So this article, I'm submitting this article as an attachment to my testimony. Okay. Now, could these points be applicable here to our own Tri-Cities community? Yes, and to wit, a recent series of health delivery initiatives independently undertaken by each of the two hospital systems and a group of independent physicians proved these points.
30 seconds.
Specifically, each of these three entities independently rolled out an accountable care organization, and each of the entities serving its Medicare members effective January of 2013. And a schedule showing the results of this is attached also with this testimony. Bottom line, it shows that the combined results of the two systems experienced higher costs and lower quality, significantly less value than the entity sponsored by the independent physicians. This documented evidence that this merger will harm consumers by bringing about higher prices and lower quality. The proof, ladies and gentlemen, is in the pudding. Cooked in your own kitchens, in your own backyard, by your own entities. Grading the initiatives by using the system introduced by the gentleman from the Department of Health, I would give Wellmont a D, Misha a C, and the independent physician entity an A+ as it ranked among the top 10 in the country, in the US this past year, among the top 10 of all the 300+ ACOs in the country. Thank you. The rest of my testimony is on file. Thank you.
All right,
Thank you.
Pause just for a second. Any questions from the committee? Okay, seeing none. Thank you, Wally.
Thank you.
All right, next we have Randy Sermons.
Hello, my name is Randy Sermons. I'm an attorney, and I'm very glad that I get the opportunity to speak with you tonight. I moved to Johnson City in 1998 to join a law firm that at the time represented Johnson City Medical Center. I did that until 2005 when I opened my own office, and since that time I've represented a number of independent providers in our community, including I am general counsel to Holston Medical Group. I am general counsel to Qualiable Medical Professionals, an ACO in our region. I am also general counsel to One Partner, our local health information exchange, which is discussed extensively in the application. And you will hear from all three of these entities later tonight. I want to say, as an attorney representing independent providers in the region, that I really agree that local control of our healthcare is very important. It's like getting a mortgage. Sometimes it's really nice we can go down and sit across the table from someone who is so involved in your daily activities. And letting that control go outside the region could present a problem. And I'm also very happy with the application making so many commitments to enhanced and additional services to really what are our most needy citizens in the region. And so I applaud those efforts. But as an external stakeholder and as an attorney representing external stakeholders, I have to be concerned about the viability of the rest of the healthcare community as we go forward if this COPA is granted. And so I want to address several issues, and the first issue has to do a lot with competition and really a lot with access, something that this group has heard a lot about. And in order to have sufficient access, it's just not the hospital systems providing access, it's the independent providers. And when you look at the application, there's a chart that defines a 29-county geographic area, and it breaks down providers in each of those counties for each of the service lines, and comes to the conclusion that there is sufficient competition in the market. I'm not sure that's really true. If you look at that list, for example, and you see CT MRI services being offered in Boone, those services do not compete with the services offered in Washington, Sullivan counties, and other counties. It may compete with services offered in Johnson County, Mountain City, parts of Carter County. However, when you look at the horizontal merger guidelines published by the Federal Trade Commission, you see that when you define a geographic market for competition purposes, you look at where the patients are willing to travel for a service. And I'm not sure that Mountain City residents can realistically travel to Kingsport for MRI CT services, or that Kingsport patients can travel to Boone. So I believe that the index must establish a way to properly construct geographic markets for competition. Right now, there are no items in the proposed index that do that. In addition, you have to compare apples to apples. Let's go back to CT MRI services. When you look at that list, it includes CT MRI services offered by orthopedist offices. Most orthopedist offices have those services for their internal patients, but they don't accept referrals from outside. They could, but as a majority of them do not accept referrals. So including them in the list of competing facilities overstates the amount of competition in the market. That's also true in the ambulatory surgery center market, where that list includes single specialty and multi-specialty surgery centers, which do not compete for the same patients. I'd also note that the hospitals have minority ownership in a number of the surgery centers, and while it's a minority ownership, if you peel back the onion there and look at the operating agreements for those surgery centers, they often contain special protections and privileges for the hospital systems to control membership, contracting, advertising, and a number of other services that prevent those surgery centers from being true competitors in the market. I'd also talk a little bit about pricing. I applaud the efforts of the hospital systems to agree to reduce their pricing to only 0.25% of the change in the medical and the hospital CPI. However, I would be also concerned about those prices getting too low and driving competitors out of the market. I feel the same way about wages and benefits getting too high and driving all of our qualified work staff from competitors into the new healthcare system. Finally, I would like to mention something about debt. The hospitals have not really addressed debt in too much detail in the application. They have noted that their bond rating should go up once they merge. I would be concerned about them taking on too much debt in the future. Part of our job here is to keep local control, and if they get in too much debt in the future, we could see another purchaser outside the community wanting to buy the merged system. Thank you.
Thank you, Randy. Just a second. Any questions from the committee?
Randy, would you just repeat what you said? The first indicator was to establish a way to construct geographic measures. I lost the second part of it.
Geographic markets.
Thank you.
Yes, geographic markets for competition purposes.
To ensure competition. I got the okay. Thank
yes.
Randy, the question is, will you be turning in your comments in writing?
I can prepare some. I'm not sure that what I've got in front of me is very well written, but I will certainly. I have prepared something to submit from the Tennessee Department of Health that covers these issues in detail.
All right.
Are you suggesting that part of the index should look at the amount of competition, whether it increases or decreases over time?
Absolutely. I mean, you are the granting of the COPA will create a monopoly of sorts. That's a hard term to define, and if you look at the technical details of how you define a monopoly, it has to do with the ability to change prices in the market by 5%. It goes on and on. But yes, in order to maintain access, which is one of our main components here, the hospital can't be the only provider of access to healthcare services. There must exist this independent provider market that can also provide that access. Okay.
Any additional questions? Thank you, Randy.
Thank you.
All right, next we have Dan Pasheen. Again, I apologize if that's not correct.
Do I get a prize for the tallest speaker?
Yes, sir.
Yes, it's Pohlgers, P-O-H-L-G-E-E-R-S. And I know that's not a very common name in East Tennessee, but I promise you that even though I was born and raised in Kentucky, I am a Northeast Tennessean by choice. I've lived here about 20 years. I actually have a pretty vast experience here in Northeast Tennessee. I spent the majority of my adult life here. Actually was recruited by Johnson City Medical Center 20 years ago to start their hand therapy program. I'm an occupational therapist and certified hand therapist by training. Worked at the hospital for about 4 years. During that time, I was actually present while Johnson City Medical Center purchased the other hospitals in the area and became Mountain States Health Alliance. I've also worked for independent practices, orthopedic practices in the area. And back in 2011, I started a independent medical practice consulting business, which I now do full-time and have been doing full-time for almost 16 months. I also have had experience working with government relations. I was an appointed member of the Tennessee Work Comp Advisory Council, first by Governor Bredesen as a non-voting member, and then I was elevated to a voting member by then Speaker Kent Williams. So I have some experience in the legislative issues and how rules are promulgated, and so I've taken a specific interest in the COPA throughout the entire process. Tonight, I want to share just 3 separate pieces of information with you that I think should be considered while looking at competition. And in my business, and what I do, especially with cost analysis and management and looking at practice analytics for medical practice, I always look at benchmarks. And there are multiple places where you can find benchmarks for the 2 entities, but there's some that are pretty commonly found, and one is the Tennessee Department of Health, and that's the Joint Annual Report of Hospitals. And I went ahead and copied, and I will submit this to you all. This is actually just one of the hospitals, Johnson City Medical Center in Johnson City. I know it's only one of the 19 facilities that could potentially come together and merge, but I think it's a plethora of information. It has information in it on what can be used for healthcare management. It looks at admissions by specialty, procedures by specialty. It looks at CTs, MRIs. All of that information is here for the year ending, and this report, the fiscal year ending 6/14. Also, it has financial data, which I think is also very important throughout the COPA application. Not only is it mentioned that local control is an important aspect, but a reduction in cost due to reduction in duplication of services is also mentioned. Also, which Randy has just mentioned earlier, decreases in the amount of increase in revenue is also discussed. And so this data here is very evident as to how that all occurs. Just as a side note, gross charges for Johnson City Medical Center for this fiscal year was $1.9 billion. Their net revenue received from patients was almost 377 million. They also received some non-operating revenue and other operating revenue, which I assume from the index and what is written here comes from the foundation and those types of areas. And I will give this to you tonight. Another piece of information, again, it's another benchmark I actually just received last Thursday, and this actually comes from the Healthcare Data Solutions, And this is actually an organization that I just recently found out about. I went to their website and put my email address in, so they send me data based on the largest single revenue sources, which is on the books, and largely pay for the operating expenses occurring to generate these revenues. This report that came out last Thursday actually shows that the inpatient revenue for hospital services in our local market, Johnson City, 4 hospitals, Johnson City ranks number 1 out of 26 in per bed revenues. So I would assume that if we're going to see reductions in cost, that those reductions in cost should also come back to the consumer, and this should also go down. I also have some information here concerning provider-based billing, which increase cost when physician groups are purchased by hospitals. And lastly, I want to mention just one thing. There's been a lot of discussion here recently about the separation agreement and the need for a strong separation agreement. That was something that Mountain States at the emergency rules hearing felt like was not necessary. But I just want to pose the question, if so much of this COPA is dependent upon local control, what would happen if after the merger occurred that an outside entity would come and purchase the merged system? And before you think I'm crazy for saying that, there's at least one other person in Tennessee that believes that that might be a possibility. And in his letter on June 25th to the Federal Trade Commission, Dr. Dreisner asked this question: I request the opinion of the staff as to whether the sale of a merged entity operating pursuant to a COPA would trigger an antitrust review when the new owner is not party to the cooperative agreement or the operating with the activity state supervision pursuant to the COPA. So if the only public advantage and the most important public advantage to this COPA is local control, I suggest that the index include a trigger that if that local control goes away, that the separation agreement is enforced. Thank you, Mr. Chairman, and I will submit this information.
Thank you for the records. Just a second. Any questions from the committee? All right, seeing none, Dan, thank you very much. All right, next we have Charlie Glass.
Thank you, Mr. Chair. My name is Charlie Glass. I'm Executive Director and CEO of the Greater Kingsport Family YMCA, where I've worked for more than 21 years. At the Y, we're dedicated to the well-being of those who live in our community. We serve folks of all ages, races, faiths, incomes, and abilities. And we believe strongly that each and every individual should have the opportunity to live life to the fullest. Today, and I'm sharing this input today from speaking on behalf of all 4 YMCAs in our region, which cover pretty much the same market area that this new health system would be covering. I should also mention that I had the opportunity to participate with the Population Health Work Group. The results of that work group and the discussions were interesting but not surprising. To see this, it was interesting to me and not surprising to see the same big 3 concerns showing up. Issues related to tobacco, diabetes, and heart. These are 3 critical issues in our region, and it's important that this new health system is involved in reducing the incidence of those people who are already have those chronic diseases, as well as preventing those from acquiring those chronic diseases. It's also important that the new health system engages with the community and the plethora of resources that already exist to do that, because there's some great resources out there. In the COPA pre-submission report, I noticed that the vision of the merger sets forth that the new health system will, among other things, build new population health models and leverage electronic health records and community engagement programs to reduce unhealthy behaviors and improve the health status of our region. And I'd like to share a couple thoughts about a possible opportunity to facilitate that vision. The first thing, I think it's important that we realize that it's difficult at best to get quality and timely data around community health and behavior health. So the first thing that it would be important for me and for us is that a system developed to identify people who have or are at risk to develop chronic disease, not just use outdated data as a baseline, but we need to start with a baseline that's relevant. Then there need to be mechanisms to make sure people are getting referred to appropriate community-based programs, whether they're treatment programs or preventive services and programs. And those programs need to have measurable outcomes that show reduction in at-risk indicators. And there needs to be funding for those programs for people who can't afford them otherwise. So there needs to be a pathway that includes measures along the way. We need to screen the population. We need to identify at-risk population that we want to target. We want an effective referral mechanism, as in a coach and follow-up, and enrollment in community-based treatment, prevention, or cessation efforts with evidence-based measures, measurable outcomes for behavior change. And those do exist. At the Y, we currently have a prevention pathway in place to reduce the risk of type 2 diabetes in those who are at higher risk to develop the disease. CDC evidence-based programs like the YMCA's Diabetes Prevention Program have been shown to reduce the risk to develop type 2 diabetes by 58%, or in people over 60 by 71%. Already in our region, we have this pathway in place with 5 regional employers, 2 in Sullivan County and 3 in Greene County. Screening takes place to identify the at-risk population. Eligible employees are referred to the program. We conduct intake sessions to enroll participants. We provide measures all along the way to show aggregate progress.
30 seconds, Joe.
Okay, this program, the results and the measures were studied for 3 years with over 7,000 participants by Medicare actuaries to be reliable, consistent, and accurate. It's the first community-based prevention effort to meet their criteria, and I think it's important that we do focus on measuring prevention. They found that at $429 a person, there's a 617% ROI in 15 months, finding a savings of over $2,600 per participant in 15 months. This is an opportunity to provide valid and credible measures that already exist that can be used to measure effective prevention efforts that this system can work with community-based organizations to provide.
All right. Thank you, Charlie. Any questions from the committee? All right. Thank you so much, Charlie.
One quick question.
Oh, I'm sorry.
Are you providing that pathway to the committee? To the Department
sorry?
of Health? Are you providing that pathway you're talking about to the Department of Health?
To the Department of Health or
Yes.
through?
To the Department of Health? The
If
pathway.
they would like to, we would.
I'd like to see
Yes,
it.
absolutely. And for those who can't afford to pay, we just need a funding mechanism.
And you think
Yes.
it's realistic to basically see improvements that we're talking about in those 3 or 4 different disease categories in how many years? 2, 3, 4, 5 years?
Yes. In fact, the five employers that we're working with, we have quarterly, and I can share with you the quarterly report that indicates, that shows the improvement and measures that we've had so far. Yes.
All right.
Thank you.
Thank you. Just a minute, Charlie. I'm sorry.
Yes.
Excuse me. Thank you. You know, I would say to you and to some of the earlier presenters too, Candy, and I'm sorry, I forget the other one, any detailed or specific examples of how programs have been successful when implemented with other hospitals would be greatly appreciated by me anyway. I'm sure the rest of the board. I would encourage everybody to post those online if you would, for our benefit.
Absolutely. Be happy to.
And if you could, if we could have the time frame where you were showing those successes, that would help.
Well, yes, the Medicare study was in 15 months. So there was, those results were within the first 15 months of participation.
All right, great. Again, we have 3 to 5 minutes at the podium, and so please be mindful of the time. And don't throw too many things at me for cutting you off when the time is up. Also, you may submit your comments in writing and submit those in the box or at the Tennessee Department of Health website. So we'll be glad to hear from you there. So we'll go ahead and get started. Next, we have Michael Longhauser.
Good evening. Mike Longhauser, State of Franklin Healthcare. I'm Chief Operating Officer. Thank you for the opportunity. You know, we've heard about some concerns, and I think those are valid concerns, but I think there are probably some ways perhaps to work through these concerns. You also heard that locally we're blessed that we have some of the highest performing independent medical groups in the country. The ACO, Qualiable, that's your local ACO, owned and operated by your independent physicians locally, depending on how you measure it, is one of the top 10 in the country, and certainly no worse than the top 20. So I think the independent physician community brings lots to the table for the hospital system to assist and facilitate this merger. And for example, on page 37 of the application talks about a clinical council. We think that something that would be very productive and very helpful would be that you have an appropriate percentage and makeup of that clinical council of those independent physicians. Again, who are some of the top performers in the country, top ACO performer in the country. It just seems logical that rather than a token representation, that you would have meaningful representation from the individual physician groups in the area. Page 44 talks about physician recruitment in the area, talks about the parties expect the combined system to facilitate this goal by employing physicians, and where independent physician groups are not interested in or capable of recruiting, I would suggest that independent physicians group are very interested in recruiting physicians to the community. What we want to do is we want to work collaboratively with the health system in order to do that. Frankly, that's what we do. We provide outpatient care. SOFA, for example, we have about 80,000 patients that we provide care to. In our ACO, there's another 22,000 patients. So we think, again, it's not for lack of interest or lack of desire. What we want to do is we want to ensure there's a seat at the table for your independent physician community relative to physician recruitment throughout the region. And we think, as you think about indexes and you think about metrics, I think you can probably assign some type of metric or some type of number that would require a certain minimum, an opportunity for the independent physicians to have right of first refusal or whatever the case might be relative to these new hires. The third area is probably page 36 in the application relative to HIE and a common IT platform. I think it's a great idea. Common IT platform is an excellent idea. Let me share with you that your independent physician groups in this region have spent millions of dollars on IT, on electronic medical record. If the merged entity comes in and potentially changes that, what that would mean to your independent physician groups could mean significant economic distress. What we would hope, again, is that there would be an index, there would be a quantitative measure that the hospital would be required to essentially assist your outpatient physicians, your independent physicians, to help offset whatever additional cost would be incurred.
I'm sorry, it's time.
Okay. Thank you.
Hang on just a second, Mike, if you will. Any questions from the committee? I have one.
Sure.
The common IT infrastructure
Yes.
is something this committee has heard before. So also, I believe I've read that both systems have invested significant amounts of financial resources, and I'm sure infrastructure into their system. But is this, are you speaking of an internal investment or common IT? Or are you speaking of external where patients can access their medical records and additional information beyond what they can now?
What I'm speaking of is a regional health information exchange that is accessible and available not only to physicians in the hospital, but also those outside the hospital, your independent physicians, your independent groups. Again, what you have today in the region is you have one partner, it's a health information exchange. Your ACO, again, one of the top performing ACOs, is using that HIE today. We would hope, and it would seem logical for the systems to make a commitment fairly early in the process, that assuming that system, it has the same functionality, capability, and is available to the systems at a reasonable cost, that they would commit very early on that we're going to use the regional HIE that's already in place. That would enable your independent physicians, again, to kind of map that strategy on the long term, versus us kind of wondering where are the systems going, what should we invest today, should we wait and see what's going to happen, because if they change that infrastructure, it could mean a significant additional investment on our part. That's really tough on the back of your independent physicians.
Okay, I apologize. I want to make sure, at least I understand this, maybe the committee does, but are we talking about a universal access system regardless maybe of what the COPA or the merged entity uses, but they'll be part of that system? Is that what you're saying?
Potentially, yes. You want the universal, you want the regional HIE to be in place, but if the hospitals choose to go from System A to System B, and that move causes significant additional expense potentially to all those outside the system, we think that should be a consideration. And frankly, we should think that the systems would be unable to make a decision that negatively impacts your independent physicians, again, who have already invested millions of dollars in IT infrastructure.
Thank you. I was jumping on the bit to pick up where Mike, I didn't know what he was going to say. I want you to picture, those of you who use your iPad today, that in 1968, I was standing on a GYN floor at the University of Vermont College of Medicine as a junior, and I was saying a 55-year-old female on a computer screen, 1968. 3 years later, I spent a fellowship with Lawrence Weed. Lawrence Weed is the father of the problem-oriented medical record. That is the standard of medical records in the whole country and overseas also. It is not an electronic problem-oriented medical record. Now, we developed this system for electronic. Now, this is what happened after his ideas came through. Because if I try to defend myself with my doctors who have been suffering, documenting all over the place and with the EMRs that don't always work, that's not what it's about. The problem-oriented medical record is for accuracy, and it's for a way of physicians to communicate. What has happened to that system, it got taken over by software writers, it got taken over by insurance companies. Just ask your doctor. He's supposed to put 8 bullets in his note if he's going to get paid at all. So the problem is in the region, these software situations become a big deal. The hospital, I was medical record chairman at one of the systems for 20 years. The hospital just spent, one of the systems just spent a huge amount for a system. And this system is well known by some that it is a monopolistic system. Once they get that system, they shut you off. We have 2 letters on the health information side, one partner, and we can expand on it, from both systems to share their data. The letters were signed quite a ways back. Let me explain to you who I'm trying to take care of. The 80-year-old lady who gets discharged on Friday night and is on IV antibiotics and on anticoagulants, okay? You have to see her on Saturday. There's nobody around here that's going to find that data between the hospitals and the rest of the systems. So bottom line, the answer to your question is this definitely has been some control. Secondly, if you're going to spend a lot of money, and that's where you guys are at, you've got to wonder what's this whole system going to do once they're together. Well, they're going to spend some more money on IT, we already know. The point of it is it going to be a system that becomes more monopolistic or not? On the second point, let me jump to David and Goliath. We know who Goliath's going to be. A $2 billion business between Roanoke and Knoxville is a Goliath. You guys are here to make sure David has a slingshot. And who's David? There's only 2 parts of the system, ultimately. There's real estate, and there's the doctor's pen. If my check comes from the Goliath, I assure you my pen is not too free. So you've got to make sure, following up on Randy Sermon's comments, that when they tell you the statistics of who's in the system and who's independent, it's your job to dig it out and make sure they don't have a bunch of false providers who aren't in the system, the banner out MRIs. Number three, I've spent my 38 years here, and just to give you an idea what that's like, if I had a dysfunctional teenager age 12, when I moved here, he's now 50 years old. I've been in the mental health system in the region all my career here. I hate to tell you, they're promising a lot of things in this COPA. They've had a hard time fixing that. We've had a monopoly, and it's not a negative monopoly. I know Mr. Varney and Mr. Good way back. They run Frontier. Frontier is a form of monopoly. Part of it is nobody else is spending money on mental health except the state. My hospitalists, who are the oldest and best, longest-term hospital team inside of Holston Valley, managed by Holston Medical Group, have told me 1 out of 3 elderly, complicated medical admissions would not have been admitted if their mental health side had been taken care of. That's not counterintuitive if you're in hospital. Remember, hospital fills beds. Am I really going to want to make sure this lady doesn't come in if I fix her mental health? I have my problems. Ultimately, the other thing I think that's the elephant in the room that's going around in the region, and economically, healthcare cannot be the employer of default. If you're an employee, if you run a business around here, you cannot have healthcare as the default employer. I can see what's happened in the county. I can see what's happened at all these places where the hospital closed. But I keep hearing from a few of the senior people in the merger, nobody's going to lose their job. I am the senior oldest full-time physician in both systems. I was working last week. In the last 2 weeks, I've had 4 teenagers, for instance, who were held on the pediatric floor, not because they needed to be on the pediatric floor, but there was no mental place to send them. They're all suicidal kids. So I live in the system. You've got to make sure David gets a slingshot. Number 2, if the electronic medical record is used as a way of controlling the group that should be independent, then you need to look at it very seriously. There are plenty of ways around. Obviously, the system that you're talking about, as far as one partner, I've been there for a long time. I told you I go all the way to 19... I go all the way back to 1968 in the EMR business. I assure you all the others are retired and are smarter than me and gave up on fixing the system. Thank you very much.